Thank you for joining us. My name is Malie, and I'm a high school student from Boston.
And I'm Amanda, a recent college grad who majored in media studies. Just like you, we're learning to become experts in COVID data. In this video, we're going to discuss how you can become a more informed consumer of COVID data, but also data in general. This is a topic that policymakers, business owners, organizations like COVID Act Now, and people like you and me are all learning about together. Nobody has all the answers, and COVID has overwhelmed many of the systems we have in place, such as our hospitals. This makes data collection and reporting particularly challenging for everyone, including us at COVID Act Now. In this video, we hope to provide some tips about how to interpret the COVID data you see in the world around you.
To start, we are going to walk through a couple of real world examples that highlight why this topic matters. Then, we will share 5 tips on things to look out for and ask yourself when you're consuming COVID data. Our hope is that by following these tips, you'll have a better understanding for what the data is suggesting and also what it's not suggesting. We hope that you feel more confident in your ability to accurately interpret the COVID data and graphs you may see on websites, the news, and social media.
Before we dive in, let's talk about why this topic matters in the first place. Based on our own personal experiences and the experiences of those of you who have written into us, we know that data is everywhere, yet the same piece of data looks different depending on where you find it. In other words, there's a lack of a single source of truth. Unfortunately, this problem is unlikely to go away. For COVID, politics, world events, and many other topics, we have to get used to sifting through various sources of information and making our own assessments. In this video, we want to share with you the kinds of questions we believe each of us should ask ourselves when we are looking at COVID data and graphs. In doing so, we hope to help you make sense of the data you are seeing and spot things that may be misleading.
To set the stage for this training, we want to illustrate why we believe this topic is so important by highlighting 2 real-life case studies. The first is an example from New Jersey. Back in July, New Jersey had a fairly low case incidence, or the number of daily new cases, but a relatively high number of deaths. This was strange because it would suggest that the death rate was higher in New Jersey than in the rest of the US. But it turns out that New Jersey's system for reporting deaths was very delayed due to the overwhelmed hospitals and morgues. Deaths that were reported in July had actually occurred back in March. It just took a while for them to show up in the system. This example shows why it's important to ask questions about data. If those looking at the data didn't know that it was highly delayed, they could have wrongly assumed that New Jersey's death rate was abnormally high.
The second example is of New York. Earlier in the pandemic, according to the data, it appeared as if New York had a high enough number of contact tracers to trace all new cases of COVID, which is great. However, in reality, New York was only able to trace somewhere between 5 to 20% of their cases, not the 100% that the data suggested. The operation was riddled with problems. Supervisors were inexperienced and disorganized, computers were deleting patient records, poor working conditions and lack of training and communication made it even more difficult for them to succeed. Additionally, there were low response rates from cases, making it hard to effectively trace contacts. It's important to not draw conclusions too quickly when looking at data. With this example, if you saw statistics showing that New York hired enough contact tracers to trace 100% of cases, you might get the impression that their contact tracing program is running flawlessly. In reality, due to the challenges faced in organization, technology, and response rates, New York was really only tracing 5 to 20% of all cases.
The New Jersey and New York examples both illustrate a key point. Numbers alone often don't tell the full story. It is crucial that we, as consumers of data, make sure we understand as much context around the numbers as possible. Instead of taking data we see as fact, we should all dig deeper and ask more questions about how it was collected and interpreted. For example, in the New Jersey case, the question could be as simple as, how are deaths being recorded and reported? In the case of New York, someone could ask, we know that New York has X number of contact tracers, but how many cases are they tracing? How many cases are left untraced?
Next, we're going to share some pointers about how to interpret COVID data.
Our first tip is, when interpreting a graph, be aware of what the graph isn't showing. We're going to walk through a few examples to illustrate what exactly we mean by that.
Here's our first example. You might recognize this graph from the very beginning of the pandemic in mid-April. It was frequently on the news. It represents the number of COVID cases by country, but there are a few misleading things about it. One of the biggest issues is that if you look at day 20 here on the x-axis and just compare South Korea and Japan, it looks like South Korea has far more cases. But this graph doesn't paint the full picture. It doesn't include any indication of how much COVID testing was going on in these two places. Were cases actually much higher in South Korea than in Japan? Or was South Korea just testing more people and therefore confirming more of the cases that existed? From what we know now, it seems like the difference at day 20 can be partly explained by testing. As you can see by Japan's rise in cases after day 20, the numbers in Japan eventually became as high as those in South Korea after Japan was able to build up its testing systems and test more people. This example demonstrates that it's important to understand what a graph isn't showing. And in this case, the graph doesn't show testing capacity, because when pieces of the information are missing, it can lead someone to misinterpret the data.
Here's the second example that illustrates this point. It shows the percent of COVID cases in Arkansas amongst people with other health conditions. As the chart shows, the percentages are fairly low. Only 0.7% of COVID cases in Arkansas are in people who are immunocompromised. On first glance, the low percentages could give the impression that having a pre existing condition isn't that big of a deal when it comes to contracting COVID. But what the percentages don't convey is that the COVID cases in people with pre existing conditions are much more severe and dangerous, as research has shown. COVID can vary drastically in how severe it is depending on many circumstances, including pre existing conditions. When looking at this chart, it's important to keep that in mind to avoid making the assumption that underlying health conditions are not that significant when it comes to COVID.
Moving on to our second tip, which is dig deeper to figure out how exactly metrics are defined.
The second action we want to encourage you to take is to ask clarifying questions about the data you are seeing. This could be relevant for when the data that is shown is not clearly defined or represented. For example, if COVID Act Now detects an outbreak in your state, check and see if there have been any recent updates to the way we assess COVID risk. In the images above, Utah went from red to dark red. However, this coincided with COVID Act Now's addition of a new fifth risk level, dark red. Sometimes a state changing colors on COVID Act Now's site isn't because the situation there has changed, but because we've changed the way we calculate risk. Is there an outbreak because the situation is actively getting worse, or is it because we have changed the way we calculate what an outbreak is?
This is a screenshot from Georgia's COVID state dashboard back in May. As you can see, one of the metrics shown is the total number of COVID tests. There are a few different types of COVID tests, but the test that measures whether or not someone has an active infection of COVID and could potentially spread it to others is called a PCR test. This is the test you've likely heard about or may have received yourself through a nasal swab. To measure how much testing capacity there is in a given state or county, we look at PCR tests. Another kind of test is the antibody test. It can tell you if you were infected with COVID in the past, but unlike the PCR test, it does not help you understand if you currently have COVID. Back in May, the Georgia State dashboard included both PCR tests and antibody tests in the total test metric. However, the number of confirmed cases listed on the dashboard only included those who tested positive for the PCR test and not the antibody test. To those who maybe weren't familiar with the details on how these metrics were calculated, they could have gotten the false impression that, first, there was more testing of active infections happening than there really was, and second, that the percent of positive cases or test positivity rate was lower than it actually was. Today, the Georgia dashboard measures PCR tests and antibody tests separately, which helps clarify the data and avoids people coming to the wrong conclusions. Remember to always look for how metrics are defined in the footnotes or legends of the data you're looking at. If you don't see a definition or explanation, ask for it.
Tip number 3 is when making comparisons over time, be aware of how changes in data might be calculated.
On August 12th, the UK's death toll was readjusted and lowered by 5,000 to 41,329 deaths. The English government changed their definition of who has died of COVID. In the old methodology, anyone who died at any point following a positive COVID test in England was counted as a COVID death. This methodology was flawed, as people could have died under many non COVID related circumstances, like a car accident, and still be counted in the UK's COVID death toll. England implemented a cutoff of 28 days following a COVID positive test for a death to be counted in the COVID death toll, bringing them in line with other UK nations. This change lowered deaths by 12%. To take it a step further, we must ask ourselves why these changes in methodology were made. Originally, there was no cutoff date to avoid underestimating the severity of the pandemic. But later, England saw the flaws in this thinking and made a change, altering critical COVID information. After digging deeper into England's change in methodology, we understand why these changes were made and where the fault lied. We can see how, when changes in methodology are made, asking what those changes are and when they occurred isn't enough. We need to ask why they occurred.
When the antigen test was first approved in early July, Florida calculated test positivity by combining results from antigen or PCR tests. Test positivity rate is calculated by dividing the number of positive tests over the past week by the sum of all tests over the past week. Antigen tests, also known as rapid tests, provide faster results, but also have a high rate of false negatives. Because of the high rate of false negatives, combining the two tests artificially lowered overall test positivity by inflating the number of negative tests. Since antigen tests are less accurate, people often take PCR tests to confirm their negative results, which can also increase the number of total tests without a proportionate increase in positive tests. Because of this difference in likelihood of false negatives, most official data sources, including COVID Tracking Project, recommend separating types of tests when reporting test positivity. On August 14th, the Florida Department of Health began distinguishing between antigen and PCR tests for test positivity. If you weren't aware of this change, you might look at test positivity in August and believe that it had increased since July because the COVID situation in the state had worsened. In reality, the new test positivity rate would seem higher only because it was being compared to the low test positivity rate caused by the inclusion of false negatives.
Our next tip: consider the broader context of the data you are looking at.
Here's one way that very similar data around one COVID metric can have drastically different implications when considered in relation to other COVID metrics. By tracking daily new cases per 100K people, we see that Oklahoma and Delaware are very similar, with 74.5 and 74.2 cases per 100K respectively. This represents a dangerous number of new cases because it means COVID transmission is very widespread. Now let's consider that in the context of another concern. Will hospitals in these states have the capacity to treat the surge in cases? Delaware's ICU headroom is only 25% used, compared to 100% in Oklahoma. Suggests that although COVID is widespread in both these states, Delaware is in a much better position to be able to treat the increase in hospital patients. Meanwhile, Oklahoma policymakers might respond by increasing their surge capacity in hospitals or implementing stricter stay-at-home measures to reduce viral transmission. Here, we can see how the same event, here a rise in cases, can have very different impact in two places, depending on the context.
While COVID data is often reported by county or state, COVID spread doesn't end at the county line. Many healthcare systems operate regionally, making it important to consider the context of COVID risk across those geographic areas. In Kansas and Missouri, 75% of all counties do not have a single ICU bed. This means that people from these counties have to travel into Kansas City for medical treatment. Severe cases from rural counties in Kansas and Missouri are all being treated within the same hospitals. So, if there's an outbreak in rural counties within Kansas, fewer ICU beds will be available for patients coming from Missouri or the Kansas City metro area. While rural counties in Missouri and Kansas may not border each other, they share critical medical resources. Therefore, COVID risk and the availability of care in Wallace County, Kansas, is directly related to Crawford County, Missouri. Without knowing the broader context of ICU availability, you might assess COVID risk in each of these counties independently when they're actually closely related.
Through the 4 tips and examples we've shared, we've discussed a number of ways that you can become a more confident, better informed consumer of COVID data. First, we've seen how, when looking at graphs, it is important to be aware of what the graph isn't showing. Second, we walked through examples that demonstrate why it's important to dig deeper to figure out how exactly metrics are defined. Third, when making comparisons over time, be aware of the changes in methodology. And fourth, consider the broader context of the data you are looking at to ensure that you have a better understanding of what that data really means.
The first action we hope you take is to apply the lessons you learned from the tips and examples we shared to your own life. Take the scenario presented above as an example. Imagine you are attending a virtual town hall about school reopenings and someone says, "We only have 25 cases in this county. That's not that bad." How might you assess that statement based on what you just learned? For example, maybe you would consider, even though it's only 25 cases, we live in a community of 500 people, so 25 actually seems pretty high in context. Or yes, there's only 25 cases, but our hospitals are actually nearing full capacity, which means any additional influx of patients could be dangerous. Or what exactly do you mean by 25 cases? Is that referring to total cases? Is that referring to new cases in the past week? What does that number really mean? Or where did you get that number from in the first place? Is it from a credible source?
Our second scenario is, imagine you're talking to your friend who doesn't take COVID precautions seriously because there is a quote 99% survival rate. How might you respond to that statement based on what you've just learned? For example, you might consider, What is the broader context of a 99% survival rate? If the entire US had COVID, a 99% survival rate would still mean that 3 million Americans would lose their lives. What is the number not showing? As more people get COVID, fewer medical resources are available to take care of people. Therefore, COVID would get more deadly for those infected. Or, how is the 99% survival rate calculated? Where is their data sourced from? We hope that you apply some of the takeaways we've shared to your own experiences and conversations about COVID.
Once you have a better understanding of the COVID data that is out there, the next step is to decide what choices you're going to make based on that data. You might be asking yourself questions like, is it safe to travel for the holidays? Should I avoid stores and restaurants? Can I visit friends and families? These questions matter because they get at the heart of the way we live our everyday lives. Our happiness, our jobs, and our health depend on finding the right answers. But there are good reasons why we at COVID Act Now can't give you these answers. First, we're still asking ourselves the same questions. We learn more about COVID every day, but there's still so much we don't know and can't yet be certain of. Second, and more importantly, these are often deeply personal questions that shouldn't be answered or applied broadly. Creating a shared understanding of COVID by applying key data and metrics across all 50 states and 2,000 plus counties is what COVID Act Now is all about. But deciding what level of health risk people should be willing to take, especially when their job, social life, and so much else is at stake, can't be answered universally. Your governor may decide to keep schools open or ban indoor restaurant dining, but you still have the power to decide if your children can visit friends or if you'll do outdoor dining. So we're not here to tell you what to think. Rather, we want to provide resources on how to think about COVID. We won't tell you what to do, but we'll tell you everything we know so you can make an informed decision that is right for you. If you're interested in learning more about COVID, visit our Learn page at covidactnow.org/learn, where you can find a glossary breaking down commonly used COVID terms, FAQs with answers to top questions about the pandemic, and explainers diving into COVID information. Thank you.